Hi, everyone. Good morning, good afternoon, wherever you are. I want to thank you all so much for joining today for our fourth session of the Child and Family Focused CCDHC Learning Community, which is focused on mobile response and stabilization services. I'm Sam Holcomb. I'm a Senior Director on National Council for Mental Wellbeing's Practice Improvement and Consulting team. I also serve as the Project Director for the CCDHC Expansion Grantee National Training and Technical Assistance Center. We're so excited to have you all here today for this important conversation. But before we move forward, we just want to take a moment to acknowledge yesterday's devastating events in Texas that led to the murder of 21 individuals, most of whom were children. Coupled with recent events in Buffalo and California and the anniversary of George Floyd's death, I think that feelings of exhaustion, anger, anxiousness, hopelessness, and stress, they're all just weighing on us very heavily. But I also can't help to think about and be grateful for the importance of all of our collective work, particularly as today we're talking about a model that's really focused on being out in the community and finding and engaging those who need the support of the behavioral health system. It's just such a critical conversation to be happening. I want to honor those individuals and victims and their families and hold that in our hearts as we move forward. We can go to the next slide. Just quickly, as always, the work today was made possible through the TTA Center, which is sponsored by SAMHSA, but the contents are solely the responsibility of the authors and don't necessarily represent the views of SAMHSA or HHS. And next slide. Our structure is a little bit different today. We're actually going to be sharing a recorded session, which was live at NatCon 22, our annual conference. So we were able to have the joy of convening this amazing group from New Jersey together and recording it and sharing it with you all today. And then we have Liz Manley, who was the moderator for that session and is just a brilliant human and has extensive work in this space, who's going to be joining us to answer any questions. So throughout the conversation, please enter your questions in the chat box. We'll answer them in the chat or we'll hold them for the end, depending on the question, and we will have some dedicated time for Q&A. Next slide. There we go.
My name is Liz Manley, and I am a senior advisor and I work at the Institute for Innovation and Implementation at the University of Maryland School of Social Work. Very happy to join you today on what is one of my favorite topics and with a group of some of my favorite folks, because I'm also the former Assistant Commissioner for New Jersey's Children's System of Care. And today I am joined with a group of great presenters from New Jersey who have all been on the ground doing this work and have a wealth of information to share with you today. So we're going to work through really what mobile response and stabilization is, what it does, and how it can be really helpful within the CCDHC world. And we're happy to take questions at the end. So these are the purpose and the objectives. So let's start about mobile response and stabilization, MRSS. Mobile response and stabilization is really about getting upstream, and it's about recognizing what happens with children, youth, and families at the beginning parts of when they begin to change in their behavior. And the intent and design is to really get upstream, to listen what parents are saying, as parents are beginning to experience the level of frustration and anxiety and worry that happens when children begin to demonstrate some changes in their behavior, both externally changes like hitting other students or getting in trouble at school, but also the other intangible things like that parents recognize around things like their change in their energy level, the refusal to go to school, the unhappiness that some children demonstrate that they can't quite put their fingers on, but are really important for us to get upstream and begin to think about how we're going to help young people and their families be able to do this work. For those of you who think that mobile response and stabilization is a brand new concept, I just want to let you know that It's not so new. It's been around quite a long time, and I've been really excited about this work for a long time. When I was the Assistant Commissioner in New Jersey, we partnered with the Institute to host peer-to-peer work with all of these states came to visit us in New Jersey and learn from New Jersey, from Connecticut, and from Milwaukee, and then eventually from Oklahoma and Nevada, who have really done some remarkable work around moving mobile response and stabilization. Many of these states are working on bringing mobile response and stabilization, and we're hoping that we can help move this work along. And this is just to give you what the continuum looks like. When we talk about children, we're talking about screening and assessment, home and community-based services, safety planning. We want to talk about planned respite. These are all really important components of what we're trying to accomplish. And that's really in this crisis prevention upstream world. I just want to emphasize a couple of really important parts of this. Number one, when mobile response and stabilization goes out, it is in many situations, it is the very first contact parents have with the public system. And we want that contact to work, because if it doesn't work, then parents get frustrated and they say, you know what, I don't understand what crisis means, I don't understand what's going on with my child, but I'm not going to call them back until things are really, really bad. And so our goal in mobile response and stabilization is to spend time in this crisis prevention world by doing screening and assessment, really connecting the dots around home and community-based services, making sure that that contact with the single point of access is friendly, supportive, nurturing, and we're going to hold the hand of those parents as they're struggling to find out what's happening with their child. We want to do 100% in-person, face-to-face with all children is our goal. Why? Because when parents across this country tell us what's happening, they tell us that if they're talked down over the phone, that they won't call the system back. If you're trying to tell them what to do, they're going to not call you back. They need to see it. They need to experience it. They need to understand it in order for them to be successful. That the use of peer support within this work is incredibly important. Parents talking to parents and young people talking to young people can be really transformational, and innovation happens from there. And then intensive in-home service, or that stabilization period where we really get to hold hands with parents through the course of what's happening for them, is a really important component. Connecting to in care coordination and making sure that we have not just formal resources for young people, but informal resources, which are so impactful for folks in the long run. And then certainly we want to be able to connect in short-term residential, if that's what's necessary, or crisis respite. I want to talk real quick about what the difference between adult crisis models and children's crisis models really are. Because I hear from folks all over the country, we do that, right? We do that. We have mobile, we go out, we listen to parents. But I want to just help you understand what I'm really talking about. In the single point of access designed to talk to parents, we're designed to talk 100% of the time. We're going to talk to parents and send somebody to help them 100% of the time. That crisis is defined by the parent and the caregiver who pick up the phone and call and ask for help. They say, I need help, and we send it. They don't even have to define the crisis in the way that you might define a crisis, right? Because they don't have the language to do that. And we don't want them necessarily to have the language before they call. We want parents to call, say, I don't know what to do, and for us to send help to figure it out. We want to respond 100% of the time without law enforcement. And I know this one gets a little interesting for a lot of folks, but I just want to say this. I was the Assistant Commissioner for New Jersey for over 5 years and responsible for the full continuum of care for children with both moderate and complex behavioral health needs, substance use challenges, intellectual and developmental disabilities, every part of it, inpatient, outpatient, all part of my responsibilities. Somebody asked me the other day, what was I most worried about? I can tell you, I didn't worry not one day that mobile response and stabilization would do what they needed to do. They would do good assessments and making sure that children were safe and parents were taken care of. I never, ever doubted that. What did I worry about? I worried about children in residential and hospitals every single day. every day. So when we talk about this work, we want to make sure that we have a skilled workforce, which fortunately we have some folks to talk about that today. And we want this work to specifically design it to interrupt care pathways that take young people to the highest intensities of service. Emergency departments, inpatient care, residential care, all start with that first phone call that parents make. If you hang up the phone and they don't get the help, those children are more likely to end up in emergency departments and the wrong intensities of service. And that doesn't last just one time when we get that wrong, that lasts their lifetime. That we want stabilization services to be upfront 8 weeks, and we want community connections to be the core of the work. So a couple of things to really think about in this work. One is, are we listening to parents and caregivers? Are we allowing that crisis to be defined by the parent and the caregiver? And you'll notice in this slide, I say different, that crisis is defined by the caller. Because if crisis is defined by the caller, then parents aren't necessarily always at the table. And we're saying in this environment, we want to level that playing field and ensure that parents are part of the solution. Because what mobile response and stabilization really is, it's meeting sense of urgency with a sense of urgency. Parents have a sense of urgency. They are feeling the anxiety. School has called, tell them their child is acting out. Pediatricians are worried. They're writing prescriptions for children not to go to school. These are the places in which we begin to see shifts and changes in children. Parents have a sense of urgency. The system must meet that sense of urgency with a sense of urgency. And this is what a good and modern system looks like. It has interruption points that allow us to get engaged with young people and their families to ensure that we're going to keep them in the right intensity at the right time for the right duration. I'm going to go one more minute. Okay. I told these guys they all have to stay on time, but we'll work through it. Okay, so we want these interruption points to really make sure that these interruption points are at the places in which we can be most impactful for children, youth, and families. In education, they're pediatricians. We're going to train and work with law enforcement because they are very good partners in this work. We just don't want them, law enforcement, to be the first point of contact. So we want to work with all of these folks so we can have really good interruption points. My job today is to talk a little bit about leadership, and I'm just going to say this. Leadership is incredibly important in the transformation for mobile response and stabilization because it requires us to shift our language and our culture to meet the needs of children, youth, and families. And what that means is we move away from words like client, cases, and consumers. We talk about children, youth, and young adults. That we focus on creating access points that are easy for families, that are easily navigated by parents and caregivers. That we create feedback loops so we know what we're doing right, and we know when we have to make changes, and that those changes are made in a way that makes sense, right? So I'll give you a quick example. If something doesn't work the way that I say it works, this is what I say to people all over New Jersey when I was assistant commissioner, then you let me know so I can fix it. Because the way that we say it works is the way it should work. That we create equity and access. 24/7, 365 days, we want to be able to access service and support for children, youth, and families, and that we're going to focus on interrupting those care pathways to ensure children get what they need. Quickly, I'm just going to tell you the two core components of mobile response and stabilization. One is a 72-hour component that is face-to-face within 1 hour, that the family defines the crisis, that there's crisis de-escalation, and there's an assessment, a child-specific assessment. And then there's a connect to 8 weeks of stabilization services that are just really important in order to ensure families get what they need. These are our partners in this work: child welfare, juvenile justice, family courts, education, pediatricians, law enforcement, emergency departments, community organizations, and more. And our goal really is to maintain young people in their own homes, schools, and communities. It is incredibly important to get children back to school when there's a crisis happening. Make sure that we're supporting them around that. That we're supporting children, youth, and their families when there's experienced trauma to ensure that trauma-informed care is not just about the child, it's about the home, and that we promote and support safe behaviors in home, schools, and their communities, and that we reduce the use of emergency departments, which are incredibly traumatizing for children. They're incredibly traumatizing sometimes for adults. I was just there. It's traumatizing for me. I wasn't even the one who needed help, but it was traumatizing for me. And so we want to assist youth and families in accessing and linking the ongoing supports and services.
Good afternoon. Oh my goodness, good afternoon. Thank you. So I want to thank Liz. And so she must have had my whole career up there because a bunch of those different connections, I represent about 4 of them. And so I'm a retired police sergeant of 20 years in East Orange, New Jersey, school principal 5 years in Newark, New Jersey, and currently the executive director for the Family Support Organization of Union County in Plainfield, New Jersey, and the executive director for New Jersey's Alliance of Family Support Organizations, and we provide support to 15 FSOs across the state, certification training, as well as continuous quality improvement surveys. And so I'm an adoptive father of 4 children, 1 birth child but 4 adopted children, and I met them while on the police force. And so I was a consumer of these services. And so let me stress something that Liz already said, is that we must meet urgency with a sense of urgency, and that the crisis should and must be family defined. Because when I call on the phone because my child who's diagnosed bipolar schizoaffective has been in a group home all of her life, and now she's in a home and struggling to adjust and to adapt, I needed someone to come to my home right away, not later on, and we didn't want the police. And so she's in the kitchen where the knives are. And I tell the person on the phone, this is what it is. And of course, thankfully, rather than sending the police, we've got mobile crisis to come out in my community and spend hours in the house with us, working with the family, stabilizing the situation, and helping us develop a plan in our community in which we could do what we needed to get done. And so I'm grateful for that, and it's important. We avoided a potential tragedy, and we avoided a police response. Because while in some communities the police come and people are pleased, I worked in law enforcement 20 years, and I know that in my community it's a crapshoot, and I'm not willing to take that risk with my children, and neither should you. So how do we support this work? How do we do this work? And so with the Family Support Organization, once a family comes into mobile crisis and they're referred to us, then we go about setting up a plan. There's an assessment that's already been done, and it's determined how we're going to work with them. Do I hit this button, Liz? I'm used to an Apple. You know, when I see this thing, I get nervous. There we go. It worked. And so what we developed in working with our staff at our agency, we service about 125 to 150 families a month. We do an assessment, which is called the FANS, a Family Assessment of Needs and Strength. And we're looking at the family's needs and strength from the perspective of the caregiver, whether it's the parent or the caregiver, and how they perceive their family. We're looking at 17 life domain areas. For example, in the instance when I gave you of my family, we'd be looking at safety. And is there an issue with safety in the home, around the community? And then a plan set of goals would be set up, and we'd work toward that. And then what happens is that at my office, I assign a family support partner to work with you. And what is unique in New Jersey is that this person is actually a peer support partner. They have a children who is or has been through New Jersey's Children's System of Care, and they're able to walk you through this process. It's a free service. We're in the community, and we work with you from 0 to 12 months. And if you need more time, then we can give you another 6 months to work with your family. And I'll just very quickly, in my 5 minutes left, walk through the top down. And so families generally come to us as intensive, and if they're highly intensive based upon the score on the Family Assessment of Needs and Strength, it's a tool designed by Dr. John Lyons, then it means we're going to have you for about 1 to 4 months. And when you see under activity frequency, we're talking about a weekly face-to-face. So initially when you're starting, because you don't know what you're doing here and you're struggling to get through, you've already had mobile crisis come out, they've done the assessment, you're getting services, we're with you every week. And we tell you that we're here to support you, and we work with you weekly. We're doing active listening. We're connecting you, engaging you, and then preparing you for child family team and all these other experiences that you're going to have that can be overwhelming. I know it was for me with my child. When we started, we didn't have mobile crisis. They hadn't gotten to Union County in 2001. And so I found myself in a room with 18 different people trying to figure out who does what, what's your name, what do you do, how does this impact my child, should I trust you, do I trust you, do you look like me, are you culturally competent, all of those things you got to figure out. And so we get to do that and help you as parents. And then we go to moderate, which means we're beginning to make progress. We've achieved some of the goals in those 17 areas that you've identified. And then you got another set of goals you want to work on. It may be communication between you and the child, communication with you and the school, and we work with you in that capacity. And so now we've got another 4 to 9 months we're working, and now you're getting a weekly phone call contact, but a face-to-face visit up to 2 times in the month. So if you notice, we're beginning to wean you off, but we're also empowering the parent to speak for their child and go forward and be able to stand on their feet and identify what their concerns are, what their issues are, and also how to get the service that they need from the community and from the service provider. So we have under Educate, it's CFT, Child Family Team details, right? What the meeting looks like, venting about the services. We're now helping the parent stand on their feet. And then our advocacy part of this is we're coaching now. We're not out front in the meeting. We're actually coaching the parent to speak up and identify what the issues are for their family. And we're observing, prepping, helping to organize. And then finally, we hope to get you to supportive, because once you're supportive, you're ready to go. You really don't need us. We're checking in with you once a month. You're calling us if it's something unusual, we might come out to visit. But now you can do this work on your own. You know where all the resources are in the community, and everything is smoking and moving along. And as you see, the goal is to sustain the resources, where to go, and we create what's called a child family team, where you have the formal supports, but also informal supports. Those are the folks who will be there when all the paid people are gone. And so now we've now found your family members, your natural supports, as well as community supports, which is how I started adopting children, right? I was a part of the support team, and I just started bringing them home, and my mother kept helping me, and I kept bringing them home, and my mother kept helping me. And so finally, that's where we are. So I just want to leave you with this thought. Again, we want to respond to urgency with a sense of urgency, and we want the family to be able to define what a crisis is, not the person on the other end. Thank you, and I'll turn it over to my colleague.
Good afternoon, everybody. I'm Wendy Davis. I am one of the assistant directors at the Children's System of Care in New Jersey. New Jersey's got a wonderful story and wonderful work, and we don't have time for it all today. The New Jersey System of Care concept was proposed by families and really driven by families at the turn of the century, and outlined mobile response as one component of system reform aimed to build a comprehensive system of care for youth with behavioral health needs. This community-based system of supports and services was designed to assist youth and family in addressing their needs earlier, and with an intent to decrease the need for higher intensity services and other system interventions. Over 2 decades later, New Jersey has developed and expanded a statewide system of supports and services designed to meet youth and families where they are and when they reach out for help and need to connect. It's a system in which standard and consistent services are available regardless of geographic area, income, or insurance. Liz stole all my best talking points, which might be good for you guys because I have many. But I guess what I would like to say is that the Children's System of Care context within which mobile response sits is really key to the success of mobile. And the system itself and mobile response, many of the boxes Liz referenced, if not all, are checked. The Children's System of Care is a division within the Department of Children and Families. I guess I'm working too many things here. Okay. Within the Department of Children and Families, the mission of which is to assist and empower all New Jersey residents to become safe, healthy, and connected. I say that very intentionally because if there's one word you're going to hear each one of us say today, it's about connection. And I'm going to go off script a little bit here, but it's a connection at every level because we understand that forging pathways for youth, for individual supports and services, not just formal services, but those connections that are so key in maintaining our youth and helping them develop and thrive are cultivated individually, and those pathways for system collaboration are key in helping forge those pathways for individual supports for youth and families. So as we go through, you'll see the system of care is a statewide coordinated network of services and supports that relies on youth and families being at the center of their own care and really aims to support them within their community with an approach that's mindful of their strengths, their cultural context, their unique family dynamic, and their youth developmental needs. And it takes into account the importance of community, environmental context, and the impact of social determinants of health. We are grounded in the system of care values and principles. I would love to spend time here, and I'm going to march on and say that we also have a standard assessment tool, which my fellow colleague Davis is going to talk a little bit about in a minute, so I'll skip over that. Liz said this, but I think it bears repeating. CSOC places great emphasis on language as extremely important in best engaging our youth and families. We've experienced times where if you sit in a room and talk, to or at people, right, it leaves them out of the equation, and it's, they're shelved. And so we really need them at the table. We need them driving the process. We need to know what's worked, what hasn't worked. And our language has to be mindful of that. It has to properly frame their needs and honor them as experts in their care. I know I've said that before, but that's genuinely how we view family and youth. This is a little bit about I'm going to skip over that. So Children's System of Care is a statewide system. We have 21 counties. We have 15 service areas that cover the whole state. And I think we're unique in that regard. And we are a smaller state, but mighty. And we have system partners. We have 3 core system partners, 4 if you include our children's interagency coordinating councils. Mobile Response, which you're all here to hear about today, and how that might be helpful in your work within certified community behavioral health centers, our care management organizations, and our family support. And I'm so grateful to my other colleague, Davis, who just shared about the work of family support, because Mobile Response in New Jersey it's not an individualized peer support model for mobile right now at this point. And that connection to the community supports, it's an array of services that our family support organizations offer to families, and you don't need to be involved or enrolled with the Children's System of Care to be able to access those. And so we're very grateful that our mobile response programs can access that individualized peer support for families, for caregivers, as well as the youth partnerships that exist under the Family Support Organization for our young people. So I wanted to talk just a little bit about the contracted system administrator. Oh, I'm sorry. Before that, I just wanted to say our care management organizations, they're our partner who really delivers the wraparound model for youth with complex and moderate needs. And they do that through child family teaming model. I'm not sure anybody here probably familiar with that, so we don't have to talk too much about that. But if you're not, see us after the show and we can talk offline about that. Our contracted system administrator, Perform Care. Oh, no, I have no idea where I am, but that's okay. Here we go. Is available, and it's one toll-free number. Anyone in the state can contact at any time, 24/7, which is a key component of our system. It helps build family reliance on our service. I know there are other states who have chosen not to do 24/7, and although at some points over the last 22 years or so, there have been very few calls at night, they've been really important. And actually, I think our call volume at night and in the evening hours and wee hours of the morning are up at this point. So Perform Care does host the access line. For an idea of call center activity, it's about, in 2020, there were over 100,000 calls, and we had a dip in there. About half of the calls historically in a year represent the total number of unique youth who interface with our system, and half of those are unique youth newly registered. This past month, about 70% of those that called were new to our system, just to let you know the need that we're experiencing in New Jersey and we know across the nation. In addition to the call center, they have many, many other functions. They, children's system of care didn't always serve youth with developmental and intellectual challenges. We did dually diagnose, but there was a concerted effort in 2012 to integrate all youth with intellectual and developmental challenges within our system. And so now our system serves youth with behavioral health, substance use, and intellectual and developmental challenges. So Perform Care does support that eligibility process, which does allow for supports and service access, such as respite and other things that are available to support the families in addition to enrich the youth's life. They offer our electronic health record, which all of our providers involved with the youth at one time can go in, and that helps with coordination of care. Certainly that's not the only thing. Our partners talk to each other all the time for that purpose. And they help us with quality, they help us with reporting, they have a number of functions. So DCF and CSOC maintain our policy authority, maintain the rate setting, maintain provider network development, and that type of thing. So when a family calls Perform Care, they'll speak to a care coordinator who will gather brief information. The goal there is really just to make sure they really don't need a rescue, right? And then they connect to the local system. And most frequently, our triage outcome is Mobile Response and Stabilization Services. And the goal there with connecting to mobile, as Liz said, is really not to gather a lot more information, but to have people go and get there, go with them in the community, see them in their environment, see them in their relationships, so that they can help identify priority needs and develop a plan. 29 seconds, so I'm going to move to some of the outcomes, if you don't mind. And I think, a lot of this, again, Liz did go over in terms of model. I do want to stress the importance of the family context and that we respond when families ask. That's family-defined need and crisis. It's always been a very broad front door, intentionally, upstream intervention. As Liz said, prior to that, we had psychiatric emergency services and ERs, and youth who needed high-intensity services had to have their families give guardianship to child protection, right? So here we go. And you'll get all these slides if you are interested. Actually, if you don't mind, Liz, I'm going to take 30 seconds and just say, because I think this is important, because many of you, are many of you here certified community behavioral health centers? So in New Jersey, a number of years back, we did pilot about 7 programs, and now there are more programs. And it was really key at that point in time that we connected with our sister division out of a different department, Division of Mental Health and Addiction Services, our state mental health authority, to plan, because we have a robust children's system of care, as you can see. And maybe we'll talk more after the service, after the show. But it was really important that we had this system that was really designed for youth and really trained to understand that kids aren't small adults. And we didn't want to bifurcate, so we really worked together. We had ongoing collaborative meetings with our sister division and with some of the programs. And actually, I'm looking at Danielle, who her agency has one. And so I remember conversations with Vera and several of the other folks at our division. And that level of ongoing collaboration has been really key and important and continues today. So we have a system we didn't want to duplicate, so we coordinated to make sure kids could connect and access what we've designed and what we've built within the context of the Certified Community Behavioral Health Center's responsibility to have that kind of response for kids and adults and capitalize on what we had already built. Is that okay? So these are not updated, but what I wanted to stress here, and you'll see this is in about April of 19. If we look from 2011 to 2021, you see a shift in the age of access, right? Almost double in under 5, and increased access by between 5 and 10, which kind of demonstrates for us that we are getting to kids earlier, and that's what we want, to get to them at their initial point of need so that we can avoid the higher end intensities later, or increasing needs. This is one of our biggest outcomes. We aim to keep kids in their home and in the community. And so for mobile, that looks like where you intervened and dispatched. Was that where the youth was when you transitioned out of service? And so for us, over the last decade, this has looked like we've maintained 97% or higher youth in their home from the start to the finish of their mobile response.
Hello, everyone. My name is Danielle Gasparini. I am the mobile director for Monmouth County, New Jersey, and I'm going to talk to you a little bit about what we do in mobile and how it all works. So when do you call mobile? When is an appropriate time? I'm going to reiterate what my colleagues have said. The crisis is subjective, and so families need to call when they think they're in crisis. I'm not going to define their crisis, because what is my crisis might not be yours or yours or yours. So it's really important. So I think it's just relevant to say it again. So why call? If a family is struggling because their child is refusing school, maybe they're going in every day late, they're just skipping altogether. If they're verbally or physically aggressive, if they are being bullied or they are the bully, if there's family conflict, if you can't sit around the dinner table together because it just escalates into some verbal aggression, that's a time to call us. Or parents, caregivers, they know their kids. If they notice that their child is experiencing a significant difference in behavior, sleeping more, isolating in their room, not socializing with their friends, doesn't seem to enjoy anything anymore, that's when you should call us. So as Wendy mentioned, Perform Care is how you access us. And we like to say, tell families not to try to do that on their lunch break. Make sure they have a good 30 minutes to make that call where they can feel relaxed and not feel pressured, because this is the time for the family to tell the operator on the other end of the phone, the clinician that's listening, what's going on, not to hold anything back. Because the more that they tell them, the more that we can help. We don't want anybody to hold back at this point. So how do you access it? We kind of talked about this a little bit. You call that 1-877 number. We're available 24 hours a day, 365 days a year, holidays, weekends, and youth over 18 can call for themselves, which is great. Even though they call for themselves, we really want to find a caregiver in their life that we can engage, because the process of our system really wants to have folks be supported by others, not just alone. The other great thing is schools can help a family call. They can do a 3-way call with a family to help them call. If for some reason the police are engaged, they can call with a family and and engage Perform Care and have us come out right away. That's really great. In Monmouth County, I'll talk about this a little more, we are partners with our police and all our screening centers, and a police department might just call me on my cell phone and say, hey, can you help us out? So I think it's important to have those types of relationships. So where do we meet kids? So I used to have this bulletin board in my office, and I would put all the places that we meet families. So I'm a social worker, and we say we meet people where they are. Well, in mobile response, we meet them literally as well as figuratively. So I've been to McDonald's and the bathrooms at one of our biggest malls, and grandma's house and the neighbor, and various street corners, at a turkey farm, actually. I mean, we had a laundry list of places that we met kids. But we want to meet them where they're comfortable, because that's where the best work is going to get done. So we meet them wherever they want us to meet them. That initial meeting, we do a crisis assessment, which we spoke about, and then depending on the level of need, we're either open for 72 hours or we're open for that ongoing 8 weeks of stabilization. What does that look like? So I probably shouldn't use a music reference because I'm not really musical at all. My mother-in-law was a music teacher, though, for 35 years, so maybe that gives me a little leeway. But I like to say that mobile response is like a conductor in an orchestra. So our job, really, is to get all the people that are involved in a child's life on the same page. So no one is doing anything for their family in a silo, that we're all working together. So our staff, not only do they touch base with the family every week, during that stabilization process, but they're also touching base with all the other players who are involved. So that could be their school counselor, it could be an outpatient therapist that they might have, a coach, whoever is on their team. We want to touch base with them and see how we can envelop that family. Earlier we mentioned about formal supports versus informal supports. Once we go away, we want that family to be left with those informal supports, that neighbor that's really helpful, that coach. And so part of that process is to engage those people as well. In Monmouth County, at the end of our 8-week stabilization, we resolve about 75% of our enrolled families. So that means only 25% of them are going on to that CMO, that higher level of care. So what happens when we have families involved for us? What kind of services do we have for them? So we have what we call IIC. We love those acronyms. So that's Intensive and Community Supports. And those are therapists that can go out to the home, meet them in the park, meet them after school, and they will do intensive therapy with our kids for about 2 hours a week. And then we also can supplement that with behavioral assistance. So they can go out and they can also help in that process. Maybe put together some behavioral plans. What I don't have on here is we also have something that's a little bit new. It's called a nurtured parent. So sometimes our parents can use a helping holding hand, and maybe they're just having a hard time, sticking with the plan or, following through with some consequences because that's really hard. So the nurtured parent can help them with that, which is really a great process. And I think this is my, we're missing a couple slides, but I want to talk about my safety plan that we do. So when we go out to a family's home, we do a safety plan. And the safety plan is a really integral part of our process. And we, as the family is talking and they're telling us what is already working for them, we're writing that on the safety plan. But at the same time, we are also looking to supplement that. And on the table in front, you'll see a bunch of items that I have, and then a couple of my favorite ones here. So when we go out to families' homes, we like to bring some concrete interventions. This started for us, it started for me. So I've been working for mobile since 2009. So it's been about 12-ish years. And I had a couple young sons at the time, and I remember going to the pediatrician and them talking to me about all different things, like these shots that kids were going to get. And I remember walking away going, gosh, I'm glad they gave me those papers that tell me what those side effects could be that I should watch out for, because there was so much we talked about. And so our concrete intervention started with this huge binder we had that we would find all information on ADHD or, bipolar disorder or whatever it was, biting or, you name it. We had, this binder was like huge. And so we would keep this in our cars. And then, an issue came up, we would leave that information with a family. And I thought, gosh, we can probably do more than that. Than just leaving some literature about, whatever they're experiencing. We could do something that's like a short-term intervention until we link them with more services. And so that was born, all these concrete interventions. So a couple of my favorite is, this book is The Fall of Freddie the Leaf, and we have a bunch of books that we typically give out. But this book is, talks about a tree and, the story of life. And so I love to give this book out if a child experiences a loss. It kind of takes you through that whole process in a way that's understandable for children. And it's just a really touching book. And it's nice to be able to leave something with a family when we go. One of my other favorite concrete interventions is sometimes we see kids who are really anxious. And so we'll bring this out and we'll teach them how to do some breathing techniques. And it's colorful and it's cool and everyone wants to play with it, and it motivates them to do the breathing techniques. So those are just a few of the items that we like to bring out. Some of the other things that I have down there on the table are bubbles, which also helps, teach kids how to slow down and, take their time, as well as a whole assortment of books. We also have adult coloring books and color pencils we give out. For kids that have elopement, worries, we have safety devices like little doorknob devices or stuff to lock the refrigerator. We kind of, as needs evolved, we kind of grew our cabinet of concrete interventions. And what we do is we have a bin in the back of each of our vehicles, and we house all this stuff there. The other thing that I thought was important is to help my staff learn how to write a safety plan. Now, it can be really intimidating, especially when you have new staff come on, and I really wanted us to be really consistent. And so going back to probably 2010, I sat with the staff and I said, let's throw everything on the table, everything that you encounter when you're out on a call, and let's put them all on this big dry erase board. And we did that. And then we came up with strategies that the staff could put on a safety plan that we all agreed were really good strategies, so that in the moment if they forget, they can, we have a flip chart. They can flip through this flip chart of safety plan interventions and write that on the safety plan. And then I know my safety plans are solid and our kids are safe until we can get those other interventions in place. And finally, the last thing that Mobile Response does is we are just this support. We are there for families. So sometimes we call a family and say just to check in, and they're like, everything is great. We are meeting with our counselor and everything's going well. And sometimes we call a family and they're like, I just need to chat with you a while. And things aren't going like I hoped. And then we're able to reassess and just provide that shoulder to lean on. And so that's really helpful too. One of the most beautiful things I think that I'm really passionate about Mobile Response. I've been doing it so long and I can't imagine not doing it. But when we get to the end of our 8-week stabilization period, like I said, 75% of our kids are able to go on without more help. And you can talk to a parent and just hear how we help them. I mean, I have goosebumps. It brightens our day that we know that we can make that difference in that 8 weeks. Right at the point when they're experiencing their crisis, we step in and we're able to help.
I'm Denise Davis. I work at Rutgers University, and we are the training and technical assistant component of our program for the entire state. And I've been lucky because I've worked with mobile before I went into actually doing training and technical assistance. So I'm kind of visual, I can't help it. Just a little bit of, we're out there and the car is on our way. So workforce development and technical assistance. Why do you need it? You need it because mobile response really needs someone who has specialized training. And they need to be specialized in understanding children and families, understanding that children are not small children, but not small adults, they are children, and that part of the challenge is that children and families, many of the challenges that the child might experience also might be a relational challenge that is also occurring with the parent. So the person who goes in needs to know how to understand and address the conflict of a child and the family together, not just the child alone. And that's what makes mobile response for children different from adult response programs, because you really have to be mindful of the parent, the caregiver, and their connection in that relationship when you go in there. Workforce development is also important because, one, we have a specialized language in New Jersey. One, we are person-centered. Two, we also have a million acronyms, and you can't go in and talk to people in acronyms and think they're supposed to understand what you're talking about. And three, we need to also be able to be culturally relevant when it comes to language, because we have a lot of different languages spoken in our state, but also we have youth who have their own language that we need to learn and understand also. And so when you're talking to a youth, you have to be mindful of what they're saying to you and make sure that you're understanding what they are experiencing. So language is so very, very important. And the ability to talk and teach the people that you're working with is a large part of the work that we do. We also are very much aware of that children are really vulnerable to crisis and that we're working with a high-risk group of children, so we have to be mindful in how we go in. And because we work with all children in the state of New Jersey, we have to have some understanding of behavioral health needs. We also have to have some understanding of substance abuse. We also have to have a little understanding of working with children who have intellectual and developmental challenges. They all are who we service, so when you walk in the door, you need to know a little bit, at least at basic level, of what it is that you're seeing in front of you. Mobile is a really tough job. I love it, but it's a tough job for someone, so you have to come in ready and prepared to do the work. And you have to be prepared, one, to go in and respond to a family who is in crisis, who are struggling to deal with each other or just with some of the mental health challenges that their child may experience. You also have to have the skill to be able to go in to de-escalate the family and get them to a point where they can sit down and calmly talk and interact with each other. And we're teaching people to do that. We also have to teach them about how do you facilitate this whole process. So facilitation skills are also necessary as a part of mobile. And then here it is, we have to know about how to interview. We need to know what some of the substances are that people are using. We need to understand that children are experiencing trauma and they might be experiencing generational trauma. So it's just, workforce development is just so important. And it helps, and as we've done this work, we've created a certification process in the state of New Jersey for mobile response. Matter of fact, there are 2 certifications that the mobile response worker has to experience. One, there's the crisis assessment tool. We use a crisis assessment tool to identify the risk factors that the child's experience. We're also identifying what are some of the strengths and the needs that the family may have along the way. And so that's the crisis assessment tool. And then we have a mobile response worker certification. And that's to just ensure that the mobile response worker has a general knowledge of what it is to respond to a crisis in a timely manner. What are the things that they need to be aware of? It also is part of training and teaching them how to write crisis plans. It's about writing safety plans. It's about how do we connect and develop resources within the community. All of that, and at the same time, looking at the risk factors that the child is experiencing and identifying them along the way. So we do a lot of training in the state of New Jersey just for people to meet those 2 certifications, the crisis assessment tool and mobile response. We have a core curriculum for each one of our system partners. So mobile has their own core curriculum. The Family Support Organization has their core curriculum. The Care Management Organization also has their core curriculum. But then there's a whole lot of other trainings to ensure that people are on top of the topics that they might need to learn about and that they might have an interest in, because we train every month. I'm saying we put on at least about 30 trainings a month, monthly. So that's a part of that. The other part of it is we provide, and I'm going to be done, coaching and technical assistance. So for our system partners, we actually provide the coaching to go out to ensure that they maintain fidelity to the model that we are actually teaching this in the state of New Jersey. We follow the wraparound model. However, we also are engaged in Nurtured Heart and a few other topics that are specific to each program, and then some that are general to our whole system of care. And so we go into those agencies to support with right treatment planning and any other topic that that agency who is a system partner would request as a need in their organization.
Right. So I think we can open it up to questions now. So I know there's a few that came in through the chat throughout the presentation. I definitely encourage those on the line to continue to send them in, and we'll try to get to as many as we can. And I know we just hit you with a lot of information, but it just strikes me as I watched this, you know, I was able to be there live and it was so powerful, but also how you all as presenters work together as a system. which I think is so representative of what we're talking about, right? So I think that is just really powerful to see. I'm wondering, while we're waiting for some questions to roll in, there was a few, Liz, that I know that you addressed in the chat, but I think are just worthy of elevating, because it looks like we had a few people who came on a little late, and things just get lost. I think first and foremost was a really good question about what are funding options to support MRSS system development.
Yeah, absolutely. It's a great question. And there are a lot of ways, I think, to think about it. One, let's start with the big one in the room, right? So we could start with Medicaid as a partner for mobile response and stabilization. That's certainly how some states have really used it. New Jersey is a good example of that. Both components are covered by Medicaid. And for children who don't meet the criteria for Medicaid, they may have commercial insurance plan, or they may be uninsured. The state made a commitment to cover those children and cover the cost of those services and supports. But there are other states that use things like the mental health block grant dollars. They use some funds. There's states that use other collective dollars, where they might be collecting for cigarette tax and some other public dollars that go into to the work. So there's a couple different ways to think about it that I think are incredibly important. But the key, I think, is to think about it consistently and think about it as a public approach. And one other thing just to remember, and that is the 2013 bulletin that went to the Children's Behavioral Health Directors from CMS and SAMHSA supports mobile crisis response specifically for children.
Great, that's super helpful. And I think it's just important, since we know there's so many provider grantees on the line too, that lens of the levers to pull for funding, what your role is as a provider, and just working within the system, I think is just such the critical component, right? You're one piece of the puzzle, and being collaborative is the way to get this to work.
Yeah, absolutely.
The other thing, do you want to add anything else, Liz?
No, that's cool.
Okay. The other thing that came up, which is going to continue to come up, and we love when it comes up because we need to be talking about this, is related to 988, right? And questions around how does MRSS interface with 988? What does it look like across the country? And how might that be variable?
Yeah, it's a great question. And it's been a complicated question a lot in the children's behavioral health world, because 988 is really coming in from suicide prevention work. And in a lot of states, it's coming from a perspective of adult mental health. But we recognize that there's a real opportunity for 988 to operate as a single point of access within the children's world as well. And so the goal is to get to our 988 planning partners within states and communities to begin to talk about specific customization for children. And that customization really is around the triage. And by the way, I would argue customization for young adults as well, that is going to allow for a more responsive or robust approach that allows us to engage both the children's system and adult system for young adults as well. So we really want to think about what does that front door look like across the continuum to make sure that we're asking the right questions and getting the right care in place for young folks. And I'll give you just one quick example how children are different in the world of adult mental health. We have someone to contact, hopefully for all that, it'll be 988 eventually. We have someone to respond. We certainly want teams to respond. But in the children's world, we think about 4-year-olds, and do we want children, 4-year-olds to go somewhere, or do we want to actually provide care for them in their own homes? We think about 15-year-olds, do we want them someplace else, or do we want to provide that care? And you heard Danielle Gasparini talk about how that care can be delivered in all kinds of places. And effectively in all kinds of places. But that's the place that the family has picked, and it's not us actually taking children someplace else.
And that, I think, is one of the most powerful things about the CCDHC model too, right? It's thinking outside of the own 4 walls of the clinic and how to be out in the community and meeting people where they are.
That's totally the power of connecting the dots between CCBHCs and mobile response, right? And when we can connect even the principles of that work, a really amazing thing can happen.
Well, thank you so much, Liz, for giving us your expertise, for convening this brilliant team. I'm going to just do a quick check with the University of Maryland team if there's any last housekeeping that we need to do. A reminder for everyone, I know there was a lot of questions about slides. You can access them on the LMS, as well as all the past sessions, and again, all the future sessions and recordings. And as always, please complete the evaluation. We really take that feedback seriously. We look at it, we use it to inform our future sessions. We debrief, we do CQI just as we ask everyone else to do. So we really appreciate your time today, and thank you, everyone.
Thank you.
Thank you for joining this month's Child and Family Focused Certified Community Behavioral Health Clinics Learning Community, hosted by the CCBHC Expansion Grantee National Training and Technical Assistance Center. Please take a few moments to complete the evaluation for this workshop using the following link being posted in the chat. We will be providing a certificate of attendance for completion of each workshop being offered throughout the entire series. So make sure you're registered with the same name logged into each webinar so that we can confirm your attendance and the total time you were part of this workshop. Please allow up to 10 business days for your certificate of attendance to become available in Ideas at the Institute. Any presentations, resources, and webinar recordings will be made available to you within Ideas at the Institute. Once you are registered for the learning community, you will have access to all the upcoming and previously recorded webinars. With our goal to support increased access to and improve quality of CCBHCs and meeting the needs of youth and families, we hope you join us again next month on June 8th, 2022 for Session 4, Incorporating Evidence-Based Practices, an array of services and supports for youth and families. You can access the Zoom link for each workshop and download a calendar appointment for that workshop by logging into Ideas at the Institute. Access the CCBHC Learning Community curriculum and click the View button for the upcoming webinar. I hope that today's session has provided you with greater understanding of the value of children's services and the role of child-serving systems as you continue to identify and implement approaches to meet the unique needs of children, youth, and young adults with behavioral health needs and their families. Thank you for joining us today, and we look forward to seeing you at the next workshop.